I really appreciate everyone for joining. This is Understanding Neck Pain, Types, Causes, and Relief Strategies. Here we have some learning objectives that I hope to accomplish by the end of the presentation. The goals are to understand the relevant structures and functions of the neck, to be aware of the various causes of neck pain, learn what you might be able to do to help yourself, to identify if and when a condition has progressed to the point where maybe you should ask for help, and overall to understand what a healthcare provider may want to know. Knowledge is power, and I always encourage all of my patients to be advocates for themselves. So throughout the presentation, I include small nuggets of information that you can take with you in the event that you see a healthcare provider for a neck or for a cervical condition. So structure versus function is where I want to start this presentation. It's relevant for problem solving that you may perform at home when trying to figure out what happened. There are three important things to consider. It's how the injury occurred, the structures in the area, what those structures do. Okay, this allows you to better understand how you may treat the problem and communicate with a healthcare provider if you can't. Now, you'll see I have three areas that are kind of blocked off here, and I'll highlight those in a moment based on the information that we cover. So first, just some relevant anatomy in the cervical spine. There are 7 cervical vertebrae. They're the 7 bones that link the head down to the shoulders and to the chest. And there's one hyoid bone, which is free floating there in the front of the diagram just below the jaw. It serves primarily as an attachment site for muscles. As you can see, this is a structure of one cervical vertebrae. There are what's called transverse processes coming out to the side. They are very small and contain small holes where blood vessels travel through. There's a central canal where the spinal cord runs, supplying most of the body with the innervation that it needs for neurological function, and the vertebral body, which supports the discs, the intervertebral discs, which are associated with some pathologies we'll cover later in the presentation. There are many, many muscles in the neck, as you can see by these 3 pictures alone. There's too many to cover, but these are just some images that I felt would be useful just to kind of visualize what structures I'm talking about. There are going to be a few that we cover as a part of the treatment method and methods in this section. There's also the spinal cord, like I said, which runs through the central canal, as well as the nerve roots. And in the cervical spine, these nerve roots come from the spinal cord, and they exit out of intervertebral foramen, which are small holes that are created by the upper and lower vertebrae at each section, and they exit out to the side, running down the arms and supplying sensation and motor function to the arms. So if there's ever any sort of sensation or motor deficit in an arm that you notice, it's likely coming from the cervical spine. So as a doctor of physical therapy, being aware of this anatomy, I would want to know where your pain is. So just some relevant questions for you to consider. Can you point to it? Can you rate it on a scale of 0 to 10? Is it towards the surface, or does it feel deeper? Is it sharp, dull, aching, throbbing, or any of the other items that I've listed here? And does it start in one place and travel somewhere else? Does it radiate? When considering biomechanics now, the elements of these structural components, these anatomical components, and how they move together, there's 2 important concepts to consider: osteokinematic motions and arthrokinematic motions. These are really large, kind of nerdy terms, but osteokinematic motions are basically what you see here in this picture. Think about them as the movements that you can see. So flexion and extension, bringing your head down or up. Right side flexion, left side flexion, bringing your heads to the sides. And then rotation to the left or to the right. Arthrokinematics are more associated with the individual issues or pathologies that we'll see. They're the glides, rolls, and twists that allow each of these cervical vertebrae to move on one another and generate their motion. They're the small sort of movement components that you can't really see, but are things that are very important for someone like me to know when treating you. So again, as a doctor of physical therapy, I would want to know how your neck movement has changed and when the pain occurs during this movement. Some relevant questions to consider at home. Does the pain get better or worse with movement? Is it only with movement, or is it constant all the time, even without movement present? Are there any movements that are limited or that you can no longer perform? Because most motions might feel pretty good, and there might be that 1 or 2 that are electively more challenging. So going back to that same structure versus function slide, you can see how the structures in the area are the anatomy, And what those structures do and how they move are the biomechanics. But there's one area that I haven't highlighted, and it's probably the most important one, and that is how the injury occurred. Anytime an injury occurs, folks always think, wow, what did I do? How did this happen? And that's usually the first question we ask ourselves. So therefore, it's one of the most important. And this is really where your taking of history begins. This is where your observation should begin. And it's called the mechanism of injury. It's the cause of an injury. Exactly how did the injury occur? When considering common causes of neck pain, there's really four that come to mind, and that is direct impact or trauma. So when something directly impacts the neck or forces the rest of the body in such a direction that the neck is forcefully shifted to one side. There's overuse, so using the neck or using muscles associated with the neck over long periods of time. There's posture, which I'm sure everybody is familiar with and has heard of before, but that's your ability to sustain either an upright posture or if you slowly fall into these passive compensatory movements where you start to become more dependent as we sit in one position for long periods of time. But then, of course, age-related changes. So aging is not a pathology. It is a normal process that happens over the course of our lives. And quite frankly, evolution wasn't always kind to us. Our bodies were not prepared to live such long, extensive lifestyles. And these parts of the body begin to wear down a little bit. And we'll observe that later in the presentation. As a doctor of physical therapy, I want to know how your injury occurred. What was the cause? So what happened? How did you hurt your neck? Have you hurt your neck in the past? Establishing a firm past medical history is very important because your injury could be the initial cause of your pain, or it could be directly related to something that happened before, and it could be a re-aggravation of a previous injury. If you have hurt your neck before, is this the first time you've heard it this way? So even though a past medical history is incredibly relevant, you could have heard it a different way before, and that can relate back to those structures and those functions of those structures that aids in the problem-solving process. And do you notice anything that makes the pain worse or better? Any aggravating or alleviating factors that might affect your pain positively or negatively? So now we know the relevant anatomy, biomechanics, and causes. This gives us plenty of information to both discover what the problem is and how to handle it within reason. I placed here on the bottom, along with relevant objective testing and imaging, because that's what's really going to differentiate the common person at home from the healthcare provider who has a lot of the information handy and ready to go to diagnose a particular problem. So what could the problem be? And this is where I really had to look a little bit more into the research to determine what would be the most relevant. I could cover a slew of topics and they could be just as uncommon as the next, and I can make this incredibly interesting, but ultimately I want this to be applicable as possible. And so this is not an all-inclusive list at all, but rather it's a list of conditions that are statistically most common, starting from things that are a little bit more mild down to some things that you should be a little bit more concerned about. Personally, most of my patients, about 90 to 95% of my cervical cases fall into one of these categories. And so they're incredibly common, at least in my setting in outpatient. But I do cover some more uncommon cases. Towards the end, there are some areas where I could fill in some of those gaps outside of what I have listed here. So a cervical muscle strain, it is an injury to the muscle belly or tendon of a muscle in the cervical spine. If you refer back to the anatomy slides, you can see that there's plenty of muscles present in the cervical spine. And it's possible to injure one of them throughout your lifestyle. Signs and symptoms include tightness and pain in these muscles of the neck based on their location. You could experience frequent muscle spasms. So if you've ever had that pulsing or tightening of a particular muscle, that is something that can happen, as well as headaches. And I put this word cervicogenic next to it. What this means is that when muscles of the neck are incredibly tight, most notably a muscle called the upper trapezius, it can actually pinch on another area called the suboccipital region. It's located here in the back of the head. And what it will do is it will pinch on some nerves in that area, which will generate this kind of radiating pattern around the head, and it stops near the eyebrow. That is called a cervicogenic headache. And in that instance, whether it occurs on one or both sides, can actually be caused by injuries to one of these muscles. And so it's an important consideration to discuss with your healthcare provider if you happen to see one for this issue. Tight muscles or a muscle strain could also lead to symptoms resembling something called cervical radiculopathy. So this is when the nerves of the neck, like we discussed before, exit the spine and travel down the arm. They have to travel through these muscles. And if these muscles are incredibly tight, they will pinch on these nerves and create numbness, burning, or perhaps tingling that radiates down the arm on that affected side. So if a right side muscle is tight, it could pinch on those nerves and cause any of these symptoms down the right arm. One other small note here I wanted to include about cervical muscle strains is a condition called whiplash-associated disorder. This is probably one of the few instances where a direct blow or trauma could cause a cervical muscle strain, since most of them are due to overuse or postural disorders. This is an injury to the muscles caused by a direct blow to the head and is often associated with a concussion. If you've ever seen some of those highlights in football, or perhaps seen this during sporting events in general, where a person's head is shifted so violently that it pulls the neck muscles with them, and as a result, can cause injury to those muscles. This affects their ability to produce force and leads to issues with stabilization in the neck. This is something that can also occur during car accidents. And so, even though you don't play sports, this is still applicable in a real life scenario outside of those very niche settings. Some relief strategies to consider. Obviously, as a doctor of physical therapy, I'm going to advocate for physical therapy, but there are some things you can use at home, such as heat or ice. Heat if these muscles are tight, and ice if they are sore and painful. I do go into this a little bit more in depth towards the end of the presentation, so I'm going to avoid doing that now. You can also perform various types of stretches or massage. You could do progressive strengthening of the muscles surrounding the neck to help build up their tolerance to that activity to avoid any kind of issues moving forward. You can use certain medications such as NSAIDs or muscle relaxers as prescribed by your primary care provider or orthopedic doctor, and work on postural re-education exercises or lifestyle modifications. These things, again, I will cover towards the end because they are recurrent and will come up as I discuss some of these other conditions here. Another common issue in the cervical spine is called joint hypomobility. These are limitations or restrictions in a joint of the cervical spine that cause it to move a little bit less than normal. It affects the osteokinematic and arthrokinematic motions, as I discussed, but it often accompanies cervical muscle strains, so there's a lot of overlap. Okay? You'll see here in the signs and symptoms that there's tightness and pain, more towards the central area of the neck because these joints are located in the spine itself. You'll note some stiffness, and sometimes you can experience some locking, clipping, clicking, or popping, which can lead to abnormal loading over time. These joints fit together almost like two C shapes, like two cups, just like this. And they rotate and they open and close. And any kind of issue related to joint hypomobility can cause these issues to occur. And you'll get this kind of locking sensation. Here we go. Apologies. Some relief strategies for this do overlap with cervical strains, like I said before, but one key difference are these joint mobilizations. Joint mobilizations are the ability to move the individual segments of the spine to help create more movement. There are certain ways to perform them, which I'll discuss later in the presentation, where you can facilitate safe movement and allow for these joints to glide on one another, which promotes more mobility and it allows for those tissues to get a gentle stretch, which is very healthy for them. We also have osteoarthritis, which is a term I'm sure most of you have heard before. Osteoarthritis, at its core, is inflammation of the cartilaginous surface of a bone. Okay? It causes progressive degeneration of this cartilage over time, thus exposing the underlying bone. And these bones fit together like puzzle pieces within a joint. And so they're in very close proximity. And when this cartilage wears down, similar to the wearing of the brake pads on your car, for instance, they can actually scrape and rub together. Maybe not causing a squeaking sound like in your car, of course, but more like causing pain, discomfort that gradually gets worse and worse as this degeneration occurs. This can occur in any joint in the cervical spine, primarily, though, in the end plates in an area and in an area called the facet joints. In this diagram over here to the right, you can see the end plates are the top and the bottom of the vertebral bodies, where you can see a lot of that spongy-like appearance. And then the facet joints, which are located in the back of the cervical spine. This is an image that I had pulled more from a generic website. The percentages that you see on the top don't exactly associate with anything that I'm speaking of here. This is more to demonstrate the anatomy and show you where in the cervical spine these structures are located. I wanted to talk in particular about facet joint dysfunction because most commonly with my patient population, these are things that appear on imaging reports or things that doctors discuss, and they don't exactly know what they mean. So in the event that this ever comes up for you, I wanted to make sure that I mentioned it here, so you had some familiarity with some of the terms, and so that way you can, kind of see for yourself what this looks like and where it's located. Facet joint dysfunction is an inflammatory or degenerative condition affecting those facet joints that are located towards the back of the bones of the cervical spine. Now, when just inflammation is present, or perhaps if there's some joint hypomobility, and these joints aren't moving, they're not opening or closing like they're supposed to, they can create restriction that you feel as tightness or pain. It could be stiffness on one side or both, and it can cause movement limitations, such as difficulty turning the neck or raising or lowering the head. This is often part of a progression that increases in severity. So just like anything with osteoarthritis, these joints of the cervical spine can actually degenerate as well. These spondy terms, as most healthcare providers know them, they're pretty difficult to pronounce, but a spondylosis is that inflammatory condition. Spondylolysis is the progressive degeneration of these areas of the facet joints. And a spondylolisthesis is a fracture of an area of bone near the facet joint that causes slipping and degeneration. We'll discuss it later in a category called spinal stenosis, but this is one of the ways that, if you leave it untreated, it could progress into something that becomes more of a problem. As you can see here in the picture on the left, you'll note some of the inflammation present at one of the facet joints when compared to what a normal joint is supposed to look like. This is the location of the facet joint, and you can see how close it is to some of those neurological structures, those yellow structures that are exiting those holes just behind the vertebral bodies. These joints, when they get irritated, normally just cause those opening and closing restrictions, but inflammation could eventually progress to swollen tissue, to this buildup of bone that can encroach on that hole there, and it can pinch on the nerve and cause cervical radiculopathy, which we'll be discussing in a few minutes. I've also included here just a progression of what spondylolisthesis looks like and how it may apply force in the cervical spine. It's very important to note that this is not a cervical spine, but very few images of a cervical spine with this condition actually exist. I wanted to make sure I included this on here just so that way you can see what folks are talking about if there is any kind of slippage in the cervical spine. You could see in the area where there is inflammation, the area above is gliding forward and the back is remaining stable, thus creating a lot of tension on the local structures, primarily on the neurological structures of the neck. Some relief strategies for this, you'll notice again, are very similar. I've included a few differences because joint mobilizations are useful only in the inflammatory stages only. If you get to those progressive stages where those fractures and that degeneration really begin to occur, joint mobilizations not only become less tolerable, but they also become more unsafe. And so it's important to know what phase of the process or what stage of the process you're currently in. If you present with a pain that is much more intense, or something that is noted as by a healthcare provider as being more intense, this is really where that clinical decision making comes into play. Another difference is traction. Traction is the application of a force that draws individual levels of the cervical spine apart, which helps to relieve these areas by creating some separation within the joints. This helps to promote a little bit of pain relief. A herniated disc is another issue located in very close proximity to these facets. A little bit about the disc just at first. Vertebral disc has a fibrous exterior and a gelatinous interior. The fibrous exterior can become thinner and weaker over time, mostly due to that overuse or degeneration, causing the gelatinous interior to begin bulging in that area of weakness. If progression does occur, the fibrous exterior can eventually rupture, causing the gelatinous interior to spill into that space, obviously leading to more increased symptoms, as well as some neurological in this case that can go down the arm on the affected side. With conditions like this that are a little bit more severe, you're going to notice much more intense pain and limited mobility. But some of the difficulties you may notice at home as we're going through these conditions is that a lot of the signs and symptoms are the same. And that's why I do advocate that if you are unsure or if there is any kind of question involved, don't be afraid to see a healthcare provider, because experts, such as myself, such as orthopedic doctors and physicians, they can make these determinations, better than the common person trying to diagnose this on their own. These are just some pictures to help, kind of visualize some of the things that I previously mentioned. You can see here the picture on the left. This is a normal healthy disc. And as that thicker outer band begins to wear away, that inner orange layer begins to protrude outward, poking on that nerve behind it and causing the problem. The picture on the right is the progression of how a disc degenerates, and are just more, facts to help improve your knowledge and to better understand what I'm saying here. Again, some relief strategies include physical therapy, heat, ice, submaximal and gentle stretching. This is because at most cases, the end ranges of motion, where you move further through the range, can become more painful because they're compressing on these areas and pushing the disc further into dysfunction. But it's important to maintain range of motion. So we encourage these submaximal gentle stretches to help keep you comfortable, to help keep you moving. And again, medications, postural reeducation, lifestyle modifications. Now, I've included traction on here, and this is kind of an area of division for physical therapists. Some research does support the fact that, in drawing these vertebrae further apart, the negative pressure actually draws this disc a little bit more towards the center and can help alleviate symptoms. This is something that, again, is only observed in case studies and isn't fully widely used in this area, but is still another tool in the toolbox, but ultimately leads to surgery in more severe cases if the symptoms don't improve. Spinal stenosis is one of the more, common, extreme conditions that you can encounter. It is a narrowing of the central canal or intervertebral foramen, leading to impingement or pinching of the spinal cord or these cervical nerve roots that exit the spine. It's usually a progression of one of the several aforementioned conditions. So spinal stenosis can be caused by that facet joint irritation, and it can be caused by the disc encroaching on the spinal cord or the nerves. And it leads to really intense neck pain, significant limitations in mobility, and often radiating symptoms into one or both arms that occur either at rest or with movement. This is a picture of what that looks like. Again, not exactly the cervical spine, but you can see how a disc or some of this degeneration surrounding the facet can cause these issues. Here we go. Some relief strategies as listed. These things are temporary at best. When it comes to spinal stenosis, most folks do have some form of pain that is always present. Although it's important to know that any of these strategies that I have listed here, while not permanent fixes, can still be utilized to help to some degree. And in the realm of empowering patients that I'm in, I always advocate for any kind of pain decrease if it helps to improve your quality of life and if it helps to improve your function, even if it doesn't fully fix the problem. In most cases, patients with spinal stenosis, we're going to try to treat them conservatively, but it's likely they may progress to surgical cases if they become more severe or if there's a progression of some kind. The last of the major conditions that I have listed before I delve into some of these treatments in more in-depth is called cervical radiculopathy. This is impingement of a particular neurological structure within the cervical spine, causing radiating symptoms into the arms. This can be caused by, again, herniated disc, the facet joint dysfunction, the spinal stenosis, and it can lead to sensation or motor function deficits in the arms. Signs and symptoms include neck pain and stiffness at the site of this impingement, numbness, burning, and tingling that goes into the arm, as well as weakness. And some of these motor functions could either be very subtle or they could be a little bit more severe and noticeable. So if you have any questions, never hesitate to reach out. That's why we're here. We're community professionals. We serve our communities as best we can by being available. And so if you have questions, never hesitate to ask. This is just a picture of what that could look like conceptually. So the picture on the right side shows the herniated disc protruding backward towards the spinal nerve root. And to the left, you could see how that could affect an area of the shoulder down all the way into the fingers. And so it's not outrageous if some of these symptoms travel quite a bit from the neck, but because of the way the nerve roots run out of the cervical spine and down into the arm, it's very important to consider that tingling, that numbness, that weakness that seems a little bit out of touch with your everyday activity could potentially be coming from a cervical issue. Now, relief strategies are largely based on the location of this impingement and are based on some of the conditions previously discussed. So if it's related to tight musculature or joint mobility, you could treat these conditions to assist in alleviating the symptoms. You could stretch the muscles, you can massage them, you can work on joint mobility and improve the way that these bones glide against one another. But if it's related to a herniated disc, facet joint arthropathy, or associated spinal stenosis, it may require surgery or it may take quite a bit of time to alleviate. It is not something that's going to go away as consistently as with the point listed here above. You can attempt to also safely perform nerve glides to relieve these symptoms. Sometimes these symptoms can mimic peripheral entrapment. This is when the nerves that exit the cervical spine and travel down the arm can be trapped in some of the muscles further down the arm, but it may feel the same. Oftentimes, I will test these nerve glides in the clinic during a cervical evaluation to be more comprehensive. If you go through a neck evaluation with a healthcare provider and they don't touch the arm at all, it's important to bring up that topic. Hey, I have this tingling, I have this weakness. Could this be something in the arm as well? Could moving the arm generate symptoms in the neck? It's important to ask these questions and advocate for yourself during your evaluation so you can gain as many answers as possible. Now, I have some other relevant conditions here. These are things that I haven't exactly listed at the beginning of my presentation. They're a little bit less common, and I wanted to briefly touch on them, but I didn't want to spend too much time because they are, like I said, less common. The first is a brachioplexopathy. It's a very complex way of saying that the nerves that exit the neck and come down into the arm were either impacted or stretched, which can generate some of those radiating symptoms. Torticollis, or wry neck as it's sometimes mentioned, is a condition primarily in infants where one side is biased much more heavily than the other, either just due to consistent feeding strategies or playing, which can result in tightness and affect development. So you can actually see a physical therapist. And I have a 4-month-old patient that I work on torticollis exercises, primarily by drawing their attention towards the other side. This helps them to naturally stretch those neck muscles and help improve their developmental progress. Cervical instability is something that you may not recognize right away. If a healthcare provider does recognize this, this is more of a medical emergency, but instead of not having enough mobility, this is when the cervical spine has too much mobility, and as a result, can put a great amount of strain, not just on the neurological structures, but on the vascular structures on the neck as well, and can, like I said, lead to a medical emergency. The last one here is a little bit of an interesting term. It's text neck. This is something that doesn't exactly have too much of a scientific name yet, but it's the phenomenon primarily seen in younger individuals when they're constantly looking down at their phone screens. People are finding that this is creating a whole host of postural issues, problems with the muscles of the back of the neck, and in some cases, even bone spurs that occur on the back of the skull. So it's important to either tell people, if you're going to use your phone, take more frequent breaks, raise it up a little higher, but don't be so hunched over with your phone in your lap, as many young adults and children are these days. Now, this next portion of my presentation is going to be discussing some of the specifics regarding these treatment methods that I mentioned before. Just the way that it is, unfortunately, a lot of these things do overlap. Rather than go in depth for each and every single one, I wanted to list them in a place that is concise so they can be revisited later, and then go through each of these treatment methods and how they might be useful for the whole host of pathologies that we've discussed. So I get this question all the time: heat versus ice, when do I use what? Heat improves the extensibility of collagen. It is a protein found in muscles, and it helps to allow those muscles to stretch. It is elastic tissue and allows them to become more mobile. This also promotes increased blood flow to an area, which allows it to, not only heal and get rid of some of those waste products that are building up within the muscle, but this just promotes proper health and well-being of the muscle tissue. It's really good for areas that are tight. Okay. Ice, on the other hand, draws energy out of the metabolic reactions that cause inflammation. So therefore, it decreases inflammation, which thereby decreases some of the localized swelling and some of the pain. Ice is really good for areas that are aggravated, aching, sore, or are acutely painful. It means, when an injury had just occurred or it occurred recently, or if there's a flare-up or a re-aggravation. Ice will be really good to sort of draw down that inflammation in a way that doesn't involve medication. It's not the end-all be-all, but it's another tool in the toolbox, and this is why we use it in our clinics. Massage has several diverse functions as well. Different massage techniques work to stimulate relaxation in the surrounding muscle tissue, which returns them to their optimal length. Muscles produce more force in this optimal length. So as opposed to these muscles being tight and tense all the time where they're much shorter, you can actually lengthen these muscles to the point where they produce more force, which allows them to better do their jobs associated with movement and stability of the neck. One other sort of niche massage technique I listed at the bottom is called a suboccipital release. This is to address those cervicogenic headaches that I mentioned before. You can place a firm, sustained pressure in this area just below the back of the skull. And sustaining that over a period of time stimulates that area of the muscle to relax, thus allowing that tension on the nerve to be eased and preventing that cervicogenic headache from happening. There we go. When you see these cervical muscle stretches being performed, I'm sure there were a couple of questions. So I've included some diagrams here. On the left is the upper trapezius, and on the right is the levator scapula. These are two muscles that are most commonly involved in nearly 90% of neck conditions that involve tight musculature. These pictures here are the end positions. Okay, I wanted to walk through them here on the screen so that way you can understand how to get into each one of these stretches, because the movement itself is quite specific. I oftentimes get the best results doing it in this way. Place your hand on top of your head for the upper trapezius stretch. You bring your head down to the side as far as you can comfortably. While holding this position, you then bring your head also forward as far as you can comfortably. After achieving this position, the last thing you want to do is keep your chin tucked and rotate up and away. And that's going to bias the upper trapezius muscle. Similarly, for the levator scapula, you'll perform the first two movements. Place your hand on your head, you'll go down to the side and then forward. The only difference here is that instead of rotating up and away, you're going to rotate the opposite direction, down and in, towards the armpit. And you'll feel this stretch slightly more in front of that muscle, but still towards the back. And these are both incredibly useful stretches, relatively easy to perform. It is important to note that when you perform these stretches, you are stretching the opposite side of the arm that's reaching up overhead. So in both of the pictures, they are using their left arm, so it's stretching the right side of their neck. When I include stabilization exercises for issues such as whiplash-associated disorder, these are what I'm referring to. Any one of these exercises or a combination can be useful. You perform chin tucks, cervical protraction, which is bringing your head forward and drawing it backward, or head lifts with holds in either a supine position, laying on your back, or prone position, laying on your stomach. Mobilization exercises, such as in the case of joint mobility, these are called cervical snags, okay? And they are exercises that allow for safe gliding and safe movement with a little bit of bracing. They can be done in rotation or in extension as pictured. The towel that they're using wraps around the back of the neck, which helps to brace these structures. And then you use the different ends as well as some active cervical motion to perform the desired motion safely, while also encouraging more either rotation or extension, which are oftentimes the most limited when using these exercises. Some postural exercises are included on this slide. Some standing rows, standing pull downs with the bands, scapular retractions as pictured here on the left, or any of the previously mentioned exercises. It's important that we continue to sit up tall, squeeze the shoulder blades back to bias the middle and lower traps, This will allow the upper trap to achieve a little bit of rest and allow for these active muscles, which are normally put into dysfunction, to participate. View the upper trapezius, which is normally a problem-causing muscle, as pulling one corner of a bed sheet. When you pull that corner, it affects the entire rest of the bed sheet that's you're trying to place on the bed. And in this manner, it pulls the middle and lower traps, which are pictured at the area of the blue arrows, out of whack and out into dysfunction. So working on these muscles is incredibly important for reducing tension on the upper trapezius and improving your posture. There we go. I did briefly mention cervical traction. These are two methods that it can be administered. The first is with a traction unit that applies force in a graded fashion based on a pre-programmed method. It applies around 40 pounds of force, drawing the cervical spine upward towards the machine. It can create some relief, but the important thing to note is that it is possible to feel a little bit of what's called a rebound effect. So oftentimes after using traction for maybe the first time, maybe the second, it's important to expect a little bit of increased symptoms initially when going back into a resting position from this traction. And that's just because you create some relief by pulling those areas apart. And when they recoil back to their natural position, it recreates your symptoms. It recreates that pathology. So it's important to consider that if you're going to use traction. Picture on the right is more of a manual handheld method that can be controlled on your own. Both of these I have in my office here and are frequently pictured in most PT clinics. I do see some questions accumulating here in the chat. I just want to reiterate that I will be revisiting this chat towards the end of the presentation and answering as many questions as I can. Some nerve glides are pictured here. You're not meant to be an expert based on the diagrams, but these are just to help set some expectations. If you were to go into a clinic and see these things used in real time, these nerve glides are meant to apply traction, and you can see all the way from the hand up to the cervical spine, the nerves in this diagram are being pulled. And so if there's any sort of peripheral entrapment anywhere in the arm, or if it's coming from the cervical spine, these nerve glides not only help to diagnose a potential neurological problem, but they also help to create some relief by creating space and allowing for movement of these nerves. So I've included here some soapbox topics to end my presentation. These are just some things that over the course of my time as a clinician, I've gotten plenty of questions about. And so I wanted to very briefly give my 2 cents on these topics. These are things that may help to serve as clinical pearls when you are trying to make decisions. They are not the end all be all, and plenty of clinicians have their own rationale. I use different rationale based on the gold standard of the latest available research. And so that is why I make my decisions the way that I do. Some folks do have some experience doing things certain ways that are a little bit more unconventional. And while it may not be listed in every aspect of the research, it's important not to discount those things. I have worked with plenty of clinicians with 30 plus years of experience who have been doing things a certain way, and it works, even if the research doesn't always highlight some of these points. The first is surrounding injections. Do I get an injection? When do I get them? There are plenty of different injections that you can receive. The most common is corticosteroids. Corticosteroid injections are potent anti-inflammatories that are injected into one particular area of dysfunction. This could be useful for facet joint dysfunctions or particularly tight muscles, what have you. But one of the points that I always get is, when do I get them? Some people do report that in cervical conditions, they don't feel any relief, and this often deters them from getting future injections. I've also had plenty of instances where I've had patients come to me and tell me they've heard of someone where they haven't worked, and thus they are nervous about getting them themselves. Injections are a great and very useful tool in the toolbox in most cases, but it's important to understand when they could be useful. Sometimes, in some cases with physical therapy, injections are better used towards the end of treatment or used later on after performing exercise, because oftentimes these inflammatory conditions are generated by movement dysfunctions. The corticosteroid injection will help to relieve some of the inflammation, but if you don't fix the movement dysfunction that causes the inflammation, it seems pretty logical that that inflammation would then restart. So by correcting that movement dysfunction, you can stop one of the root causes of the inflammation and make a better impact with a corticosteroid injection utilized later on in the treatment. Another question I get all the time is related to imaging. When do I need it? Is it useful? Do I live and die by the imaging, or do I go another route? Imaging can be an incredibly useful tool in a couple of different scenarios. If you've been treating conservatively, such as with physical therapy or with medication on your own perhaps, and you find that you're not getting any relief, and you've gone through an evaluation, it's very important to find the root cause. Clearly, conservative management in this case isn't working, and so imaging is recommended to view the structures that are relevant and determine what's going on. Imaging is the gold standard for diagnosing most cervical conditions. It's not always the first step because physical examination can do quite a lot. It's important to know what those conditions are. Well, it's really important for your healthcare provider to know what those questions are and those conditions are, but also too, just to better understand where it can play a role in the process. It doesn't always have to be the first choice, but it could be a useful tool in the toolbox if you find that your symptoms are not resolving. Finally, posture. I am big on promoting proper posture. When people sit with a forward head posture and rounded shoulders here, that can increase the amount of force placed on the cervical spine by up to 3 to 4 times the amount of force. Normally, about 12 pounds of pressure go through the cervical spine. And in some of these cases, it can go anywhere from 36 to 42 pounds of force. That force really helps, and it contributes to a lot of these conditions that people are experiencing. And this occurs over time. So if you wake up one day with this neck pain and you're like, where did this come from? How did this happen? Is it something that occurred overnight in your sleep? Was it traumatic? Or was it an accumulation of these small little moments where these postural deficits aren't being addressed? So it's really important to be aware of your posture, and you're not going to be an expert. Nobody, even myself who is hyper aware, has the perfect posture all the time. I simply take my phone and I set hourly postural checks. It seems very silly, but quite frankly, that small little detail can help improve how you feel, and the amount of force going through the spine is greatly reduced over the course of your day. In summary, to kind of cap my presentation off here, be a good historian. Document the cause of the injury, location of pain, etc., all of the things I mentioned from the beginning. This knowledge of anatomy and biomechanics, as well as some of the things that happened related to the cause of the injury, can only strengthen your ability to be an advocate for yourself. Communication is key. Most common conditions of the cervical spine can be caused by very similar injury mechanisms. Remember, I only mentioned 4. Most of them are due to age-related changes, posture, overuse, or these direct blows or these trauma cases. So this can complicate self-treatment for someone who may lack the knowledge to do so. If you're trying to fit one of these conditions in those niches, it's very difficult to do so. And even then, a lot of the treatments overlap. So it's important to know that a doctor of physical therapy is a movement specialist. Don't be afraid to seek help if you need it, okay? You can use some of these strategies if you have a good sense of the anatomy, you have a good sense of how you hurt yourself. And if you want to try any of these stretches, any of these smaller exercise, you can do so with very little risk. But just remember that physical therapists are here to help in the event that you need any of that additional support.